Hello everyone. Today we'll discuss treatment of SMA, that is Spinal Muscular Atrophy, recent advances. Okay. The Spinal Muscular Atrophy, it is a so we'll start with an introduction. It is an autosomal recessive disorder. It is an element type of lesion with a progressive weakness and muscular atrophy. With a progressive weakness and muscular atrophy. Okay. So the genetics and the pathophysiology behind this is SMN1 gene, that is lack of SMN protein. So SMN protein, full form for this is survival motor neuron. So SMN1 gene, it is present on the chromosome number 5q13, which encodes SMN protein. So the chromosome is number 5q13. Okay. So when there is a complete lack of SMN protein in human, it is very lethal. That is leading unto the SMA. And there is a complete lack of SMN protein in human is lethal. Okay. So what is the primary role of this SMN protein is? So we'll see the primary role. So primary role of the SMN protein is to involve the assembly of snRNP complexes that is required for mRNA splicing. So its primary role is to involve assembly of snRNP complexes that is required for mRNA splicing. Okay, so this is the role of SMN protein. So when there is an absence of SMN1 gene, the motor neuron survival depends upon the diminished amount of SMN protein that is produced by SMN2 gene. So when there is a absence or complete lack of SMN1 gene, motor neuron survival depends upon the diminished amount of SMN protein that is produced by SMN2 gene. So what is the difference between SMN1 and SMN2 gene in the production of SMN protein is that in SMN2 mRNA lacks exon 7. So it lacks exon 7 and produces a protein product. So when it lacks exon 7 and it produces a protein product, this is being degraded. Okay. So exon 7 is included in only in the minority of transcripts. So that will only produce the functional protein. When there is a lack of exon 7, that when it produces a protein, it will be degraded. Okay. So when the SMN2 gene, when it produces with exon 7, when the exon 7 is transcripted, it produces protein which is a full length. It is a full length SMN protein this is being used. Okay, have you understood? So I'll do it with a simple diagram for you here. So this is SMN1 gene DNA. So when this is mutated, when this is absent, completely absent, there will not be no mRNA. There is no mRNA transcription and there is no protein. There is no full length protein here. Everything is being degraded. Okay. Next we'll go into the SMN2. So this is SMN2. Here it is axon 6, 7 and 8. When the axon 7, this axon 7 is being mutated or when it is being not present, we will be having this mRNA, but here there won't be any full length SMN will not be present. So the protein will be truncated and degraded. Only a 20% of the mRNA will be transcribed into a full length. This is full length SMN protein which is being used in the patient. Okay, so this is about the genetics of SMN, that is SMN. So now we will go into the treatment. First, SMN, we have two types of treatment. One is SMN dependent therapies, another one is SMN independent therapies. First we will see the SMN dependent therapies. In SMN dependent therapies, we have 3 drugs. First is nusinersen. Second one is onasemnogene. Abbvie parvovic xoy. So onasemnogene, Abbvie parvovic xoy. Third is risperidone. Okay, we'll see about each of the drugs mechanism of action and their dose. So first is nusinersen. So nusinersen is nothing but a antisense oligonucleotide which promotes the inclusion of exon 7 during the splicing of SMN2 RNA. So it is an antisense oligonucleotide. So this will promote the inclusion of exon 7. This will promote the inclusion of exon 7 during the splicing of SMN2 mRNA. Okay, the route of administration is by intrathecal. So route of administration is by intrathecal method. Dose is 12 mg. Okay, here initially 4 loading doses are given. So there is initially 4 loading dose followed by maintenance dose. However, these 4 loading doses are given as first 3 loading doses are given every 14 days. So first 3 loading dose are given every 14 days, and fourth dose is given 30 days after the third dose. Fourth dose is given 30 days after the third dose. Okay. Next is maintenance dose. Maintenance dose is given every 4 months once. The cost of this Myostatin is 93 lakhs per dose. Okay. So this is about the Myostatin. Next we will see about the Onasemnogene Abbvie. Onasemnogene Abbvie. Okay. So this is an FDA approved one in 2019. So it is an FDA approved in 2019. It is mainly approved for the children before 3 years of age. This drug is used for the children less than 3 years of age, and it can be used in all types of SMA. It is a single dose, mainly based on the weight. It is a single weight based dose. Route of administration is through intravenous route. The side effect here is there will be an elevation in the liver enzymes tropi, and there will be platelet count reduction. So there can be an elevation liver enzymes, so leading to liver toxicity, and tropi as a reduction in platelet count. So because of the concerns of this liver toxicity, patient should be treated along with the steroid. So due to the concerns for liver toxicity, patient should be treated along with steroids. So they have been given oral prednisolone at the dose of 1 mg per kg for 30 days, and this dose is being tapered over next 28 days. So the LFT, platelet count and tropi should be measured weekly for the first month, and the investigation should also be done before starting of this drug. So the cost of this drug here is 16 crores since it is a single dose. Okay. Next we will see about Risperidone. So Risperidone, the mechanism of action is it increases the splicing efficiency at exon 7 in SMN2 mRNA. This increases the amount of functional protein. So these can be produced in the absence of, which is being produced in the absence of SMN1 gene. So it increases the splicing efficiency at exon 7 in SMN2 mRNA. Thus it increases the amount of functional protein. So it increases the amount of functional protein. So it is given route of administration by oral route. It is approved for the children more than 2 months of age. Okay. The cost is, it is rupees 2 crore per year. So this is about Risperidone. Next we will see about this. So these are the SMN dependent therapies. So one is nusinersen, next is onasemnogene, Abbvie, next is Risperidone. Okay. Next we will see about the SMN independent therapies. So SMN independent therapies. So in SMN independent therapies, first is promotion of muscle growth. So for promotion of muscle growth, so we will talk about myostatin. So myostatin is, it is an endogenous protein that limits the muscle cell growth. So it is a endogenous protein that limits muscle cell growth. So it limits the muscle cell growth. So we have to make a anti-myostatin antibody that targets the latent form of protein and prevents the activation in muscle. So what is the anti-myostatin antibody? So anti-myostatin antibody, here they have designed it as SRK015. Okay. So since it is an anti-myostatin antibody, it targets the latent form of the protein and prevents the activation of the myostatin in the muscle. So this prevents the activation of myostatin in the muscle. So this is being under the phase 2 trial. Okay. Next is enhancement of muscle function. So enhancement of muscle function. So improvement in the efficiency of muscle force generation is also a target. So improvement in the efficiency of muscle force generation. This is also a target here in the treatment of SMA. For this we have the drug called reldesemtiv. It is an activator of skeletal muscle troponin and it increases the force of contraction. It is reldesemtiv. It is an activator of skeletal muscle troponin. Okay, so and it also increases the force of contraction. So this is about the recent advances in the treatment of spinal muscular atrophy. So SMN independent therapies and SMN dependent therapies. In SMN independent therapies we have SRK015, which is an anti-myostatin antibody, and reldesemtiv, which is the activator of skeletal muscle troponin, and it increases the